components, red and white, and she was discharged after 7 days on some oral medications, and the distension had decreased according to the parents. Over the next 6 months, the child was active, eating well, and gaining weight. The distension, however, persisted and remained static. There was no history of fever, no history of jaundice or edema, periorbital or pedal edema, no history of breathlessness, no history of loss of appetite, nausea, decreased oral intake, or decreased urine output, no history of altered sensorium, lethargy, or vomiting, no history of any bleeding manifestations, hematemesis, melena, petechia, purpura, no history of any behavioral abnormalities or involuntary movements, no history of any alteration of bowel and bladder habits, no history of joint pain, swelling, or rashes, and no history of any chronic alternative medications or toxin exposures. Antenatal history, it was a registered pregnancy. USG scans were normal. Iron and folic acid supplements were taken. There was no history of fever with rash or PIH or gestational diabetes. Birth history, full term normal vaginal delivery. The baby cried immediately after birth with the birth weight of 2 kgs. There's no history of NICU stay. The child is immunized till day. All age appropriate milestones were achieved on time, and the child has good scholastic performance. She consumes a vegetarian diet and has a calorie deficit of 300 kilocalories and proteins of 4 grams. Family history, the father is 32 years old and the mother is 30 years old. They have three other children who are alive and well, the eldest being a 12-year-old boy, and the other two children are also alive and well. Socioeconomic history belongs to lower socioeconomic class according to modified Kupusamy scale.
Come, you all can come here. आप बैठिए, माजिद बैठिए, बुलाता हूँ. Okay. So what are your initial thoughts on a 10-year-old child with abdominal distension for 3 years? And this is the story. Insidious in onset, progressive over 1 month, more in upper abdomen. What are your initial thoughts?
So, according to the history, the swelling is noticed over a period of 1 month, um, and it's more in the upper abdomen. So, looks like it's probably organomegaly more than, because it's not generalized abdominal distension. Um, and uh, yes, but with some medications, they're saying that the distension decreased. So probably the organomegaly had really decreased.
So, yeah, so now we start thinking. So, first part is absolutely right that you are thinking that this is organomegaly. But the question is, which organomegaly presents as abdominal distension and decreases with medication? Let's think.
Splenomegaly in malaria or chronic infections.
So good. So we've started thinking that splenomegaly can decrease with medication, but splenomegaly usually doesn't present as abdominal distension. It will present as a lump, isolated. And with liver, then it will be liver mainly, right? So can liver decrease in size on treatment? What are your thoughts? What do you think? Can liver decrease in size? Come on, quickly. So which hepatomegaly? So acute liver will decrease in size or chronic liver will decrease in size? So which liver decreases in size on treatment? Hepatitis will decrease in size, not necessarily on treatment, with time. Then you name first everything, then we will see how many of these present with abdominal distension. Liver abscess after treatment, okay. Any other liver that decreases in size? Congestive cardiac failure. Okay. But the point is, none of these are likely to present as abdominal distension. They'll come with other complaints. So, this history that the abdominal distension seem to be slightly less is either just their perception, or which other abdominal distension actually decreases and increases. In other words, which is waxing and waning, which is not organomegaly. What are the other causes of abdominal distension? Tumor. Will it go up and down? No. So what else? Other cause of abdominal distension. Fluid. Can it go up and down? Up and down. Once up and once down, but not up and down, up and down. Gaseous distension. Very good. So gaseous and feces. So constipation and flatus can go up and down. So that's the totally different story. Fine. Now, if this child was active, eating well, and had no complaints, then mother noticed that the child was not gaining height. So, what do you think of this?
Some chronic disease.
So, if the chronic disease has started affecting the height of the child, then would the child be active, playful, and eating well? So, these two things don't seem to gel well with each other. So, there may be some lacunae in the history or in mother's perception or whatever, right? So, what could be the possible reason so far anatomically? So, you've said abdominal distension, mostly organomegaly. Organomegaly means mostly liver. Now, till this stage, what could be the which part of the liver is involved?
Parenchyma seems to be involved.
Okay, parenchyma. So, what is the pointer to parenchymal dysfunction?
One, there is evidence of ascites.
That's later.
Late.
I'm saying till now. So,
Had there been biliary had there been biliary involvement, so then there would be jaundice and other symptoms which are not there here, but
so biliary involvement is out.
out. So we are looking at parenchyma then, and
Are we looking at venous congestion? Are we
And-
looking at reticuloendothelial system?
no, because there's no pallor or anemia description in the history, or
Yeah.
bleeding history. I mean, bleeding history not important, but anemia, pallor history is not there.
Okay. So you are saying that reticuloendothelial system is theoretically possible, asymptomatic hepatomegaly, but then if it is, it should come up with some other symptoms of other systems. Okay. What about venous system?
Then ascites,
Very
generalized
good.
should be
So,
generalized abdominal distension should have been there.
so far you're sure that it's not venous system, not biliary tract. You're debating between parenchyma and reticuloendothelial. For parenchyma, you need to be very uh, detailed in your history, whether the child is having any kind of loss of appetite, reduced playfulness, etc. And if the mother has really, so did you ask this question pointedly about growth in height, which the mother said?
No, sir. The father actually, both the both the parents, they themselves put forth that actually they noticed it when The younger sibling outgrew her, who was considerably younger. So then they noticed that she wasn't grown.
So that's a very strong history of poor height gain that the younger sibling has outgrown. Okay. So until that time, this child was active and playful and eating well. Yeah. So if that is true, then it is without dysfunction that the height is being affected. That's a bit of a question mark. So,
I think this history tells us how difficult it is to take a history. Okay. How can we not make out anything with this history? So that means we have failed to kind of think and ask upfront something. First thing is, uh, if you look at the first paragraph, in a 1 month's time, there is a progressive increase of upper abdomen, which itself looks very much not usual. How can an organ like a liver increase in 1 month? Okay, so quickly. So you could have started asking, how well was this child prior to it? Okay, and I think we have been saying this again and again that start your history saying how well was the child. Now you don't ask, पहले ठीक था हाँ एकदम ठीक था. Now that is not the way. Was she gaining weight? Was she gaining height? Was she eating well? Was she active? Was she playful? But her bowels are okay, urine is all right, sleep is all right, behavior is all right. If you're not well, one of these things may be upset. But if you ask, has she been all right? Yes. What is all right? For many students, passing an exam is all right. For people like you, 98%, not good. What is good and bad is relative. Now, unless we ask that, we won't know. Let's believe this child was all right. I don't believe it. Okay. Now, if she was not well, what was not well? Did she have any symptoms, fever, cold, cough, diarrhea, vomiting, whatever? No, sir, nothing. Then was she gaining weight? Not much. What about gaining height? Ah, sir, she's not been gaining height. So you start constructing a story of a short stature coming up, whatever the cause, in a child who has an abdominal distension. So you build up a story like that. Okay. But when we don't know that and we only go by that, which abdominal distension can increase in 1 month in a healthy child who remains healthy? And my impression is only ascites. And that too ascites largely because of a venous congestion. Venous congestion. And post-hepatic, yeah. So, but today post-hepatic is earlier we used to see toxic, etc. So some hepatic vein obstruction. Okay, which could be acute, subacute, chronic. 1 month is fine, but that would have not come with only upper abdomen. So this is only upper abdomen and not spleen to begin with. Again, you could have asked, what is upper abdomen? Right, left, all. Then they might say, all. That means now spleen also. So spleen, really the parents talk about a lump. But that needs something more of understanding. Okay. And therefore, we could have asked all those questions. Because what is important is this child is eating well and remaining active. What does that mean? Which diseases keep you well, eating well, and active for several months? Can you give a thought? Which diseases give you no disturbance in health, eating, active, but still disease? Chronic liver disease? Chronic liver disease must fail to thrive, not chronic liver disease. So why does this happen in clinical medicine? What is the physiological basis? So unless you go down that, you will not pick it up.
so which category of
Yeah.
diseases? Think of that. So start talking of pathologies or categories, and then you'll come to know. So you think inflammatory diseases have no symptoms? They have symptoms, right? So like that, which category will initially have no symptoms and the child will be fine. Storage. Storage.
Okay. Storage to begin with will have nothing else. When storage continues for a long time, there will be many things. So storage is one. What I want to say is that when there is a catabolic state, you start losing weight, appetite, etc. And what is catabolic? The difference between intake and output. Okay, either intake is less and output is more, or both. That is catabolic. This is not a catabolic disorder. That's number one. And it is not disturbing the functions. So, non functioning kind of, or normal functioning, maintaining, and not catabolic. Could it be a cyst? Could it be a benign tumor? Yes. Okay. We are just talking about liver only. Now, that got little better, but you say slightly better. Now, slightly better may not be better at all. Okay. In the exam, you say, what about chest? Sir, occasional crepes. I have always asked the candidate what was the occasion. How can you say occasional crepes? Okay, there is nothing like occasional crepes or mildly congested throat. So that slightly bothers me a little, but suppose it is really so. Then which of these illnesses can cyst go down now? Can tumor go down now? Can a hepatic vein congestion go down? Yes, maybe they gave a diuretic. So we'll keep back again on hepatic vein congestion. Okay, we are not sure about this, but this clearly tells you. Now, why should a hepatic vein congestion fellow not gain height? So that's another problem. So now we combine the two. Which condition has a short stature and an abdominal distension? Short stature is thyroid, growth hormone deficiency. Okay, they don't have abdominal distension. The thyroid fellow may have, but more important is the delayed milestone, etc. So it is not bad. Is it a chronic infection? No, there is nothing going on. Is it any musculoskeletal disorder? No. So we would have asked at that time, do you have any defects in the bones, legs? See how, unless you think, you will not ask this question. But suppose we say the answer is no, there is no bony defects. Then what else can have not growing well in height, not in weight, but height, and still abdominal distension? Give a thought. Causes of short stature, endocrine out, chronic problems out, rickets, achondroplasia, chondrodystrophy out. What remains is the cause, and therefore a chronic progressive anemia, hemolytic anemia, thalassemia, but whatever, spherocytosis. They would have. The moment you say that, eh, have you seen a mild icterus? Is the next question. If that was so, it's spherocytosis. And then one of the parents are also short, diagnosis is made, autosomal dominant sclerosis. So far, I'm not talking about fluid coming in. So, but this would have been a thought process, and thereafter he continued for a long time, and just 6 months prior, that means in between there is almost 2.5 years. So it remained static. Got one blood transfusion that could have saved them from further worsening, and thereafter the story again comes up. Now this time there is probably a lower abdomen also. Now, does liver cause lower abdomen? However big liver is, it can't reach lower abdomen.
So what must have happened?
There you got diagnosed. It must be a spleen. So lower abdomen is spleen, starting from upper abdomen to lower abdomen. Again, you are not talking about the flanks. Okay, diffuse. Lower
So
abdomen.
later flanks also.
Okay, all right. So probably, but if that was so, we would have asked right from beginning whether it's only right or left, etc. I'm just pointing out that after years of experience, if you ask me which part of clinical story is difficult, taking history is the most difficult. And most of us have forgotten history. The country has forgotten the history of independence. And we are taught not even a blood was split anywhere. Okay, क्या कमाल कर दिया ना, खून भी नहीं बहा, मगर in, we got independence. How history is totally belted. Right from 1857 to 1947, people have lost their blood and life. But we sing a song, oh, no loss in blood. What nonsense. History is that difficult. Of course, that history is suppressed. Here, we suppress that history by not asking. So I think let's go about.
So
I
now,
tried to make out what best I can.
yeah, now apparently there is generalized distension with flanks. So that means what? Ascites or fluid.
So go back to hepatic venous congestion. Okay. Now, all is still difficult, but let's go on. At, at least such things teach us how we should be thinking. Whatever comes out is different, right?
So now there are two thought processes. As Sir said, one is go back to hepatic venous congestion. So there we are giving importance to the fact that the original liver enlargement, which caused which was organomegaly and which got abdominal distension, and was happened in a short time, like 1 month. And Sir asked which causes. But then from then to getting ascites, the gap of 2.5 hours is too long. 2.5 years is too long. So that is one thought process. And the second thought process is this parenchymal dysfunction of the liver now coming up or manifesting as ascites, in which case your original history of not being, of being active, no loss of appetite, etc., was wrong, and all that was slowly happening over a period of time. So that could also be a
Only point is, if short stature is an important finding, nothing of that kind works. Okay. And therefore, again, we need to ask, but you said that the younger one has overtaken the height. Then that is quite significant. So I would give a lot of importance to short height. And then the only possibility is a chronic hemolytic anemia. But how can we
explain
figure out
fluid. Yeah.
ascites? Now, how much fluid was removed? You could have asked that also. Okay. Suppose somebody just got 5 cc. Everybody's abdomen has some, and they might have managed to get something they call V-tap fluid. So I think these are the issues that we are not sure.
Okay, now 10 minute बैठो माजी. माजी 10 minute बैठो. So now
Once,
in a 10-year-old girl, when you're talking of lack of height gain, do any other thoughts come to your mind? Age is also important, no? 10 years. So at 10 years, what is also happening and not happening? Puberty. So you will have to take that into consideration and ask questions related to that, whether there is onset of puberty or no. Sometimes the younger one shoots up because the younger one has achieved puberty and has shot up, and this child is yet to achieve puberty.
now 1 month distension is not a slowly progressive distension. The child has developed progressive distension, gradual. It's not gradual. 1 month is too fast. Any organomegaly in 1 month is difficult. Only a congested or vascular phenomenon, if what we have assumed is correct, has to be in 1 month. Then later on, it has been relatively stable. So this processes whatever that problem was, and we have already discussed. I think the hepatic side disease producing significant abdominal distension in 1 month is too fast time. But and has remained silent for a year of time is fine. But if it has progressed to such extent to produce abdominal distension in 1 month and has remained so, we don't know that whether the abdominal distension was so fast or not.
Sir, I am just not sure whether we can take that 1 month as sacrosanct and whether that is, deviating us.
Later on, whatever was there was, so to say, not getting decompensated. The decompensation has begun over last 6 months. Growth failure to me means problem at the cellular level. Maybe it hormonal or maybe it transfer of vital important substances like oxygen, especially, and cellular metabolism. Of course, hormones are there, but this doesn't gel well with hormone, and delayed puberty will usually present with other problems. I mean, it may not be the presenting manifestation. So I think something has started early, has remained silent, and has now come up. And the way it has come up is decompensation in the form of ascites, definite. What is definite is abdominal distension and ascites. And you mentioned that there was distension at sides also, not only lower down. Yeah. So I think ascites, significant ascites. So whatever the cause was there has now resulted in decompensation with ascites. That means only two possibilities. One is decompensation of a liver function, hypoalbuminemia, uh, portable hypertension, and ascites. That means we have to go back to a chronic liver disease, and of course at a cellular level rather than that.
Sir,
And
that,
only
as we said, if the short stature preceded that, then that doesn't gel well.
yeah.
The liver failure.
I was just thinking that short stature may be a totally different thing. Keep that in mind. And then I have one more suggestion, and I recall having seen such a patient. A child came with a right-sided upper abdominal swelling, which went on increasing over time, maybe over a few months, but otherwise was symptomatic. And thereafter, suddenly started developing ascites, and the reason was hepatic vein obstruction out of a tumor in the liver. And I don't recall what turned out to be that biopsy. I don't recall that, but I have seen this child, and then it foxed us completely. Of course, those days there were no CT, MRI, etc. So we had to just wait on. And because the child was all right, we did not even consider any histopathological diagnosis. And that child developed an ascites. So hepatic vein obstruction out of a large tumor. Now we know that hepatoblastoma could be asymptomatic, and a benign tumors could also be asymptomatic, but that short stature. So too many gaps we will have to fill up with exactly a clinical examination. Yes, but this is a good case to remind us. History taking in this child would have taken me half an hour, and even then we normally now start saying history reliable. Okay. Balasubramaniam in Chennai keeps on asking candidates which mother is not reliable. So he said, I don't like you should say reliable. Every mother is reliable. That he always makes that point. But anyway, let's proceed.
So we are compelled to make a diagnosis of ascites, which probably looks undisputed in this
Yes,
particular
and
child.
not a liver disease.
And
And
now
not
we have to
tuberculous
explain.
peritonitis.
Not
Sure.
so we ascites is definite. Hepatomegaly is probably definite of a long duration because it has started with upper abdomen. So chronic liver disease with
No,
ascites,
no
which has
chronic liver disease in this child. Child is active and playful. No, chronic liver disease is out.
but whether the decompensation will take place over
No,
a period of time or no.
no, even decompensation will with ascites, but compensated liver disease is a liver function abnormality. Cirrhosis, compensated, is certainly a failure to serve.
Then the
Okay.
other only explanation could be both hepatomegaly and are as a result of post uh, sinusoidal or
Yeah, but
after
that's
that's
what we
very
have been
worried. Yeah.
discussing. Yeah.
Venous obstruction, something like bursiary, cardiac problem less likely. Bursiary can present at any time. It can explain progressive abdominal distension over a short time and then relatively normal period and then decompensation when the liver is affected. Initially only hepatomegaly, but usually with ascites even at that time in the beginning, but they probably in the beginning there no detectable ascites. Probably a vascular phenomenon or liver disease still to be kept in mind.
Actually, on this note, I want you to take a note of no history, negative history. You always say no history of liver disease. But are you considering a liver disease in this child? Then don't say that no history of liver disease. Okay, no history of jaundice. Are you expecting jaundice in this child? No. So we said no history of seizures, no history of unconsciousness. You mean the parents would forget that to tell you? That you have to ask So negative history is something that parents may not have thought of importance to tell you. And for you, it's very important. So don't give me the all possibility cause of ascites, short stature, etc. No history of delayed milestone, thyroid is out. No, not that. That's not a good idea. Come, let's start.
And blood transfusion, white and pink, that means platelets were affected, anemia. So another system is also getting involved. Maybe the platelets were affected probably because of increased destruction as a result of splenomegaly, less likely to be as a result of hemopoietic process. But RBC series and platelet series are also, at least two series are affected either due to increased destruction or decreased formation. Decreased formation perhaps
Yeah, but
less,
what is
but very
applicable here? That is theoretical. What is applicable in this story? That is important.
Come, let's examine and then see if we can get wiser, and we'll take your findings later. Come. So come, 3, 4 of you come and somebody start examining and tell us what you think.
One of you hold.
One of you hold.
And the other one talks.
Child
comment on stature. 10-year-old.
for a 10-year-old girl, child looks short, and she's averagely nourished.
Nutrition.
She's saying averagely nourished.
Average. So short stature is an issue. Okay. Average nutrition and less of height is certainly not a malnutrition. So we have a short stature. Okay. Look at the mother or grandmother. She's also short, maybe. So keep that in mind. Okay.
Child is non-sick looking, oriented to time play, oriented and conscious. There is no jaundice visible, and there is mild pallor. There is hyperpigmentation over the knuckles and bony prominences.
Vegetarian?
Vegetarian. Okay.
Why did you?
Why did sir ask?
Because megaloblastic anemia,
Okay.
vitamin B12 deficiencies.
Okay.
And many in this group may take non-vegetarian, but once a month, once a week. So they are also vegetarian. And they don't take much vegetables also. So I don't know which.
Okay.
Abdomen appears distended, sir, and also
One sec. We want to know about hemolytic facies. So,
No,
so what are the parts of a hemolytic facies?
sir, there will be prominence of the maxilla and overcrowding of the teeth. Then, which is hypertelorism and frontal bossing, which is
So does
not
she have
there.
any of those?
No, sir.
She has malar prominence.
Frontal bossing also, cause may be different.
There is mild.
Okay. Fine. Go ahead.
Abdomen appears distended.
Is there edema?
There is no edema,
No,
but there is
probably not, at least on inspection.
platinicia is there, sir.
So when it's there in the lower limbs, next you should look at what? One nail or multiple nails?
Multiple nails, but not in the upper limb. It is only in the lower limb.
Fine. Go ahead. Abdomen. Inspection.
Abdomen appears distended with flanks full. Umbilicus is lower.
One sec. Flanks full. Everyone agrees? Flanks full. Don't go by USG report. Go by your eyes.
See, if you look at this abdomen, then it is more like this. Okay, and if it's an ascites, it's like so. The flank would be a little full because everything is stretched, but this is not a flank fullness of an ascites, and therefore, if you see from the head end or the foot end, you will find that it's coming more in the center rather than on the flank, and therefore, don't call it a rank clearly. So ascites may be there, but not enough to cause all that distance.
Probably what we wanted to say is there is distension centrally also, but in non-ascitic patient, central distension big and prominence in the flanks nil. You're definitely central distension, as you said, sir, is definitely. But I don't expect the flanks also to be full only in central distension.
No,
But if
what I
there's a
meant was, just hold it here. If it's a liver disease, it's like this, and then ascites, it becomes like this. This child is not doing that. This child is here and a little distant. So possibly this is not a typical chronic liver disease going into ascites. Of course, venous hepatic venous congestion is a chronic liver disease. Okay.
the left flank also. Can you appreciate that?
So, sir, what I thought when these students have to talk of flank fullness, they have to talk of this area. Now, this is absolutely flat. It is not bulging. So, this is what you talk of as flank fullness. Okay, go on.
Sir, umbilicus is um, below the center, and it is not stretched.
So, the better words are umbilicus is somewhat pushed
Push
down.
downwards. And there is no dilated vein.
Is it stretched?
It is not stretched.
It is slightly transversely stretched. It's not a typical smiling umbilicus, but
There is no visible dilated veins. Um,
visible but not dilated.
and there are no sinuses. There is a dressing bandage, might be some post procedure, and all four quadrants, no icterus. All four quadrants of the abdomen move equally with respiration.
So, as sir was saying on history, you keep thinking and expecting. Now, with this inspection findings, what are you expecting on palpation? Keep thinking. So, what are you expecting?
Organomegaly.
Okay, only liver or spleen also? Hold, close.
Both.
Both. What fluid, how much fluid are you expecting?
Minimal to moderate fluid.
Okay, so minimal maybe, but definitely not massive. Okay, fine, go on, palpate.
Ask her to fold her. It may be a good rule to ask her to breathe also.
Lamba se sasti. Spleen I am able to palpate. Spleen I am able to
Did you
palpate.
try to palpate all along the borders, or when you felt one place you were happy?
Borders I didn't palpate.
I mean, it may be in spleen only, but in the examination, when asked to justify, borders are there, notch is there, all those things you will mention. Is there a notch?
smooth and round borders. Not able to appreciate
How many lobes are
hepatomegaly.
there in the liver? You didn't come
Right
to the
and left.
yeah. You didn't come to the left.
Left lobe of the liver is palpable. Right, I'm unable to. Left lobe of liver is palpable.
Right lobe. So there is no significant hepatomegaly. That's what you are saying. Okay. Don't forget to palpate the upper border.
Sir,
Spleen is there.
liver is not palpable, sir. Spleen is palpable with the notch. Um, it is above the umbilicus, just touching the. No, it is midway between the umbilicus and the coastal margin.
When you can't feel the liver, then how will you judge the consistency? The left lobe is available.
Actually, the mass in the epigastric, it is. I thought it is spleen entirely. It is in the epigastrium, and it is actually spleen, sir. Left lobe of the liver, I could not palpate.
So it's a shrunken liver. Big spleen ascites, shrunken liver, and you are not able to palpate it.
If you want to palpate a liver which is just palpable, you should have asked that patient to take a deep breath, gone there, and at least you would have been able to feel the edge of the liver. Absolutely not palpable looks little difficult. That means the liver is so shrunken that you can't even feel the border of the liver, neither in the right lobe nor in the left.
See, if you had asked upper abdomen means what, right side, left side, you might have got an answer straight away. Okay, this is important. And I think that's where learn to ask all details. Okay. It's not rare for us to, when I ask so many details, then people come out and say, जल्दी समझता नहीं बहुत पूछते रहते हैं ओके मेरा डॉक्टर तो कुछ पूछता नहीं एब्डोमिनल डिस्टेंशन बैठ जाओ चलो देखा पता चला वैसे मुझे टाइम लगता है बहुत थोड़ा सारा पूछना पड़ता है बट आई थिंक लर्न टू डू दैट to me it's
Or
extremely rare that history cannot guide you in the right direction. You may not reach the destination, but direction. Here we were directionless. That was a
लंबी
worrying
सांस
feature.
और लंबी ले 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 और लंबी ले ले left lobe I can feel here. If I trace on the right side, बेटी ले ले लंबी सांस. Liver is just palpable but not very firm. I would have expected a firmer
But
liver.
left lobe is firm.
Left lobe is firm.
What's
Definitely.
what's a possible diagnosis? Large spleen,
Here,
ascites,
ask him.
left lobe
Don't do
firm.
that. Not. This is the
Congenital
left lobe border
hepatic
and this is the bottom.
fibrosis.
They are
Left lobe major involvement,
And
asymptomatic till
for
there is a decompensation.
no.
And now you have
They लगा के देखो, it's
portal
quite
hypertension.
firm. Yeah,
Yes.
firm to
It
firm.
looks like a pre-sinusoidal portal hypertension. Okay. And if the left lobe is firm, it's
That is
really
why it is important.
pre-sinusoidal
All the
intrahepatic portal hypertension.
There's definitely this is spleen. Then there is a dimple here. Okay, this is the beginning of left liver border and quite firm, sir.
So I think if this is so, I've never seen a left lobe uh, firm unless there is a tumor there, but the tumor is different. Here it's only an organ enlargement, and therefore to me it's a congenital hepatic fibrosis with a slowly evolving pre-sinusoidal portal hypertension. If you don't take that liver, you would say that this is typically an extrahepatic portal hypertension. But what I'm trying to talk about is pre-sinusoidal intrahepatic, and that's congenital hepatic fibrosis, and it behaves exactly like this. Of course, the history we could not have guessed that, but to me now on examination, it's a congenital hepatic fibrosis. Still proves otherwise, and such patients also have a kidney problems coming up or already there. So silent kidney problems, enlarging kidneys, palatable, all that may be difficult with ascites there, but I think that would be a possible diagnosis so far. Yes, how we could be misled by the history, right? This is very, very important. I think this was really teaching us something besides how to talk about, but so important in the history.
Sir, does congenital hepatic fibrosis present as hepatomegaly to start with?
Yes, only thing is that it takes for some reason, I don't know the reason just now, it takes the brunt on the left lobe of the liver. And this has taken, right lobe is hardly enlarged, but the left lobe is enlarged. Normally, right lobe is enlarged.
Sir,
Okay.
can it be that both lobes are shrinking, but a left lobe
No, if
is
the
available to palpation while
no,
right is not?
she would have gone down. Shrunken liver in pediatric practice is almost never seen. And if it's seen in adults, they are very sick. They are chronically, progressively going down. So that is not that. That's why I call it that. But just because we are discussing this, what's the difference between fibrosis and cirrhosis? Cirrhosis has fibrosis. No? So what is difference between cirrhosis and fibrosis? Yes. Cirrhosis is fibrosis with regeneration. And fibrosis is no regeneration.
Also,
Okay.
there is pseudo lobe formation because of regeneration and
Yeah.
fibrosis.
Now I don't fit in blood transfusion there. I don't fit in short stature there, but it could be genetic. So I think we have many things not understood. But this is not a hemolytic anemia with a large spleen. This is not chronic malaria. This is portal hypertension. But pre-sinusoidal, to me, intrahepatic. Anyone wants to palpate, please.
You present your summary and then your examination findings.
The summary,
Mike, Mike.
10-year-old girl brought with complaints of chronic abdominal distension with splenohepatomegaly and firm nodular left lobe liver with no signs of liver cell failure.
Acha, this is after examination you are giving?
Yeah, I came to the.
No,
Yes.
no, no. Give your history ke baad and then give your examination findings.
10-year-old girl brought with complaints of chronic abdominal distension, probably hepatomegaly, with one episode suggestive of decompensation with ascites and transfusion requirement, and with growth failure. Developmentally normal and immunized till date, is most likely a case of chronic liver disease, secondary to autoimmune causes or metabolic, and Budd-Chiari syndrome. On examination, the child was conscious, oriented to time, place, and person, afebrile, the pulse rate of 90 per minute, vitally stable. Anthropometrically, there was stunting with height between -3 and -2 standard deviation, BMI of 16.1, -1 to 0 standard deviation. Head to toe, the
Just instead of saying say that height age is this much and weight for height, it means little more clarity. So 107 centimeters is the height of a what-year-old child? I mean, granting for the hereditary factors.
117, what age?
Come on, this is
Make it
simple.
simple. 100 centimeters at 4 years and 6 centimeters every year. So 4 plus 3 is 7. Okay. So you must have this at the, not tip of the tongue, outside the tongue, because examiner expects in 3 years you have weighed and taken height of so many patients. How can you not have a right on the...
Without interpreting at that time. And the weight for height for 7-year-old child is 21 kilos. Am I right? So what is your opinion?
Go back 1 minute. Height and weight. Yeah.
Never lose the opportunity of interpreting this. So 121.1 low, but not too bad.
Yeah, in fact,
Yeah.
I mean, very arbitrarily, both are nearly 7 years of age, and therefore, what Amdekar sir made the point, and BMI 16.1, so it's not malnutrition at all. And if both are nearly 7 years, then you really start wondering whether it's constitutional, familial, what, or whether it's related to the disease. You'll have to think carefully.
In fact, this almost tells us that this is constitutional or genetic, because even a chronic disease would have got the weight also down. So this is constitutional, and you see that lady, she is also short. So I suppose it is either constitutional or genetic. But what's the difference between the two? I thought the constitution is short, which is genetic, no? So both are genetic only, no? What is constitutional short stature and what is genetic short stature?
Is there a word after the word constitutional? Delay of what? Of growth and puberty. So the full word is constitutional delay of growth and puberty. So what's the difference? Sir is asking.
The final height achieved would be matlab, would be height would be achieved but after a certain delay, while in case of genetic, that compensation after a certain age won't be there.
Sir,
So
I've
both look short initially, but the constitutional delay will catch up later and become normal, whereas familial or genetic will remain short. That is the...
And in such a case, you must always ask the parents which one of you two looked short during early growth period. And that is very, very typical. And then one of them will say, or both of them will say that, oh, at adolescence we picked up. Right?
mid-arm circumference
So
may
for
be more significant in under fives, but sir, clinical impression was that our arms are not as much as we wanted. No wasting, no loss of subcutaneous tissue, but
But weight for height is not too bad.
Head to toe examination, the hair appeared dull and lusterless. There's no facial dysmorphism. She has dental caries. The chest appears normal, hyperpigmented knuckles and feet. Abdomen was distended. There were no signs of liver cell failure. Spine was normal, genitalia normal, and SMR staging was prepubertal.
Ascites is sign of liver cell failure.
So she's talking on general examination.
Yeah, okay, all right.
For abdomen inspection, the abdomen appears distended, upper abdominal quadrants more than the lower, and there's no flank fullness. There were no dilated and tortuous veins, scars, or pulsations visible. All quadrants are moving symmetrically with respiration. Palpation, superficial palpation, soft, in all the quadrants, it was soft and non-tender. Deep palpation, liver, left lobe of the liver was palpable, 2 centimeters below the xiphisternum, firm in consistency and nodular surface was appreciated. And spleen was 8 centimeters along the long axis, firm, smooth surface and rounded borders. Percussion, tympanic note is heard. There was no evidence of fluid collection. There's no shifting dullness present. And auscultation, bowel sounds are heard. Rest of the systemic examination is within normal limits. Clinically, sir, I could not get any signs of
But she was
fluid.
stabbed, no?
No, a liver biopsy was done. There was no.
But you mentioned some fluid was removed, something like that.
That
No,
was
no,
in the
that was
prior.
history. Some time back.
The fluid was removed or it was a dry tap, or we don't
No,
know
fluid
that.
was removed. The quantity is not known to the parents. Summary: 10-year-old girl brought with complaints of chronic abdominal distension with splenohepatomegaly and firm nodular left lobe of the liver with no signs of liver cell failure and stunting. Developmentally normal, immunized till date, is most likely a case of chronic liver disease, secondary to autoimmune causes, metabolic like Wilson's, with portal hypertension, storage disorder, or Budd-Chiari syndrome.
So I think sir was just internally discussing. So we need to discuss this and understand our differentials. So see, the biggest point against chronic liver disease is that for a chronic liver disease to make the right lobe vanish, this child is too good in terms of not sick, in terms of no ascites, no edema feet, no jaundice, no episode of hematomesis, nothing. So that chronic liver disease is not tenable. Okay, that kind of a parenchymal dysfunction is not tenable. It's too much of a disparity, right? Coming to storage disorder, again, the inequality. I mean, you could have a something like a only spleen which takes the brunt, but there should be some liver, no? There is a irregularity in the liver. So that is why that storage disorder also doesn't fit in. You don't have a only left lobe in a storage disorder. You would have splenohepato, but hepato generalized, right? And Budd-Chiari is out because there's no ascites, right?
I think what you possibly mean by chronic liver disease is this is not a chronic liver parenchymal disease. Okay, but that doesn't still, to my mind, rule out a fibrosis because fibrosis is outside the liver parenchyma, but will gradually involve that. Okay, and to that extent, if you say chronic liver disease, you may have to specify that it's not a primary chronic parenchymal liver disease. And that's why viral hepatitis B and C will have jaundice and then progression. Wilson's, yes, for a long time, 3 years, Wilson's has not produced any hepatocyte dysfunction. So that's not right. Storage disorders never have only the spleen to begin with, but over time, liver, bone marrow, multiple things, and then there will be no ascites in storage disorder, and therefore that's not. But cherry will have ascites, but a large liver. So possibly, if you ask me, really, I am maybe biased to say that left lobe is firm, so it must be a congenital hepatic fibrosis. But many things are amiss. I may be totally wrong.
Yeah. Investigations.
This is the complete blood count. For the first one is in the month of September last year when she was admitted 6 months ago. She had a hemoglobin of 5.7, hematocrit of 17.2, microcytic hypochromic, and platelets of 1.1 lakhs and total counts of 2000, which was 64% polymorphs. The complete blood count during our admission showed an HP of 13, hematocrit of 37.8, MCV of 87.7, MCH of 30.1, platelets of 99,000, and WBCs of 3,900.
This was pre-transfusion.
The one on 11th was pre-transfusion.
Okay, so just looking at this CBC, what are your thoughts in general and then for this child? Yeah, all cell lines are affected. One. Second, so is it leukemia? Only from the CBC, no history, no other details, no peripheral smear.
In leukemia, it will be lymphopredominant. Sir.
Okay, 1 point. What else?
And platelet.
Last MCV.
Yeah, blasts will be there. That is in peripheral smear. What else?
Platelet 1,19,000 is near to the lower border.
No, that's not a reason. See, that's why you should, it's complete blood count. No, look at the other things. Now, what are the two other things that is given to you? What is the MCV and what is the MCH? Both are low. In leukemia, your hemoglobin goes down acutely or chronically? Acutely. So you should get a normocytic normochromic anemia. So this is microcytic hypochromic. So this is deficiency anemia. So that though on the first impression it is pancytopenia, but you know that this anemia is a little chronic. I'm just making you think. Nobody is going to tell you from this you diagnose or rule out leukemia. Now coming to this girl, what do you think is the cause of this CBC? That time.
The chronicity.
And hemolytic.
Nutritional anemia, why? Fine, but why platelet should be low? Why WBC should be low?
Hypersplenism.
Very good. Hypersplenism. No, this girl has a big spleen, so it could be hypersplenism. So there is a big element of deficiency anemia. Add to that hypersplenism, so all three cell lines are down, right?
Liver LFTs, 6 months ago, total bilirubin was 0.8, total proteins are 7.6, serum albumin 3.15, and OTPT was 121 and 37. The investigations now showed a total bilirubin of 0.5. Total proteins and albumin did not get processed in the report. And SGOT-PT was 170 and ALP was 356. PT-INR was 16.5 and 1.37. And USG abdomen showed gross splenomegaly, prominent portal vein with periportal edema, raised echogenicity of the liver, feature suggestive of chronic liver parenchymal disease, non-necrotic abdominal lymphadenopathy. And a hepatoportal Doppler was done, which was normal. And she underwent a liver biopsy yesterday.
Fine. So next time, please let us know the diagnosis of this girl. Don't forget. And if you don't come, send the message with your friend what is the diagnosis. Okay? Today, yes, sir.
Actually, when all that you know is when they have said features of chronic liver parenchymal disease, what radiological chronic parenchymal liver? All that they are saying is liver is abnormal, but they don't know whether it's a hepatocyte or any reticuloendothelial system outside the hepatocyte. That is not there. And again, if you look at the total proteins were all right. Yeah. So where is the liver dysfunction? So this is the hepato involvement without dysfunction and mainly the spleen. So my diagnosis still, I'm biased. Once you start thinking, you see only that. Okay, but please let us know that. I think this taught us too many things.
If there was real ascites and was tapped, then sir, liver dysfunction is there.
Sir, so that time there may have been liver dysfunction, but today, sir, clinically also there is no ascites, and today's hepatocyte function is normal.
It can't be that there was decompensation there and now there.
In fact, the typical congenital hepatic fibrosis is on the verge of liver cell failure, which means bilirubin is slightly raised, proteins are reasonably all right, and then some intercurrent trigger factors will make them decompensate and again get back. And what is that decompensation? Mild bilirubin increase. Okay. And I think this is a typical story of a chronic liver. The congenital hepatic fibrosis, they come to the doctor only because of a bit decompensation, but decompensation quickly comes back because the uh, trigger factor is transient. And I think to me that reasonably fits in well. Okay. Anyway, good. But this is important. Okay. When I have a clinic on Wednesday at the SRCC, again my complaint is next week there will be different people joining and I won't know what happened last time. And if I don't know in a week's time, I will never know. Like Dr. Merchant said, if you have a problem today, go home in the night and sort it out. Otherwise, if you have no time today, you will have never time again. So please make sure if you are not there, let somebody else report to us what has happened. Yes, we must also learn, right? But good. I think you did a good job. You stimulated our gray cells so much that we understand that I don't have enough of that as of now. Very good. Good job.
Especially, I liked your physical findings. The left lobe, picking of the left lobe, the firmness of left lobe, the paucity of right lobe. The right lobe is still there. It touches your hand and goes, but you must ask her to take a deep breath. And there are some limitations on how much deep breath. But I saw you, all of you palpating, but nobody asked her to take a deep breath and palpate.
And also, when you can't feel a liver, then obviously you have to start percussing also from the top, no? And find out where is the upper border and look at the liver span and all that, right?
Can you turn the patient to palpate the liver which is not palpable? Spleen, we do that, no? If spleen is not palpable, you turn to the right. What about turning to the left? Yes, you could do that because these organs are not work. Even the brain is not fixed in our cranium. Okay, there is a few millimeters gap between the bones and the brain matter, and that's why earlier days small infants used to be thrown up and catch, and that has caused intracranial hemorrhage. So brain also can move, and spleen, of course, even liver. So it's not a bad idea to do.
And if you see that now, it is child abuse. Because lifting the child and picking does not produce any overt sign. The clue to the diagnosis is fundus examination showing hemorrhage. Mhm.
Play football with their head, they hit with their head, they also get intracranial hemorrhage.
So today I will be presenting short case. 5-month-old male child, first by birth order, born out of non-consanguineous marriage, resident of Govandi, Muslim by religion, came with complaints of cough and cold since 3 days, fever since 1 day, and increased work of breathing since 1 day.
What are your thoughts?
Hello.
So don't, I mean, make it a habit not to use the word LRTI because it's a very broad word. Okay, so try to be little more specific.
Symptom has started with cough and cold, so airway involvement is there, uh, followed by fever and increased work of breathing. So, uh, and a 5 month old child. So bronchiolitis is one thinking.
Yeah. So the cough and cold here, of course, you need details to ask how significant is the cough and cold. If it is trivial, mild, then it's just like a prodrome of an illness. Then you ask for details of how high is the fever and then the breathlessness. But yes, you are right that it sounds like the story could fit in with bronchiolitis. Is it pneumonia? So discuss points for and against. It be a pneumonia.
So the symptoms could have been reversed, like fever would have been the first
Very
complaint,
good.
followed by
So usually there is no cough and cold. It should have started with fever. But can a pneumonia become breathless in one day?
not in a normal lung. It should have some anatomic
Okay. So
abnormality
either if there's a malformation or the host is
malformation,
abnormal or
immunocompromised.
or highly virulent organism. Okay. Or what is the age of this child? So younger the child, faster will be the progression, right? So those thoughts you have to keep in mind.
I think cough and cold go together, but there may not be cold at all. There may not be cough also. So make sure cold is running nose, blocked nose, and many times cold and cough is one term only. So take care of that. Considering that, could it be a heart disease? Anything that happens between 3, 4, 5 months with such a story is still proved otherwise a congenital heart disease. Okay. Especially if it's a well breastfed baby, gaining weight well, nobody in the family having any problem, then where is this infection coming from? Then there's a congenital heart. Would you say, could it be a congenital heart? Let's forget the cold part, I know that, but cough, yes. Okay. Fever is just a trigger, and you have a breathlessness. So could it be a congenital heart disease with left to right shunt, cough, and then all that? Come on, just give a thought. Give a thought. Anything.
Feeding difficulty.
Excellent. See, you started thinking, but every breathless child has a feeding difficulty, right? Yes. So now go further in the same direction.
Uh,
So how is the 5-month-old with a congenital heart who is showing left to right shunt and now fever? Is he growing well? Manifestation so early in infancy must have been a moderate or large shunt. Child may not be doing well. So first question is he doing well or not? If he's doing well, breastfed, fatty fellow, bronchiolitis. If he's not doing well, a congenital heart. Could it be a congenital lung malformation? Again, a congenital and breathless. So could it be a cystadenomatoid malformation? Okay.
Could have presented earlier also if it was
That presents like a pneumonia
pneumonia.
and not like this. He said pneumonia starts with fever. So that would have started. So this is neither congenital heart provided we know how the child was prior, otherwise bronchiolitis. Right?
Incidentally, sir said respiratory child would also be breathless. So how will you differentiate between that not feeding of a respiratory breathless child and difficulty in feeding of a cardiac child? What history will you ask? Carefully.
Difficulty in feeding every time the child is sucking, so he's not able to suck well, and uh, he's not able to continuously suck. He's not gaining weight, and he's irritable, and uh, mostly these are the
So
symptoms.
suck rest.
Suck rest suck cycle is there.
No, so suppose there is a bronchiolitis. What is the respiratory rate normally of bronchiolitis? Arbitrary.
For
60, 80 above.
Minimum 60,
60.
otherwise 70, 80. Okay. So at a rate of 70 and 80, will this child be able to suck? Do you know that when you suck, you have to stop breathing for a second? You know that, right? When you have to suck and swallow especially, you can't breathe at that instant. Now 80 per minute means one breath per second, or even less than that, zero point 0.8 seconds one breath, and that breath is inspiration and expiration in zero point 0.8 seconds. So this baby will not be able to feed to begin with there itself, versus the heart disease baby
Rajesh, you'll have to unmute yourself.
so understand this history properly and then take it, right?
Now, good, the word apparently all right has not, so far it has not come, but that's the most important. Whenever you ha- Whenever you have a child with a respiratory problem and if the child is small, don't call it a respiratory problem. Call it what? Cardiorespiratory problem. The idea of telling is that you are easily likely to forget the cardiac problem because the child presents with a respiratory problem. Okay, so as he said, suck restless like you are not doing well. Then, then
All viewers, please mute yourself. All online viewers, please mute yourself.
and then increase work of breathing and also palpate. The mother feels that there is precordial hyperactivity. She has perceived that when she touches that. These are common things which the breathlessness may come up a little later, obviously. But all these 5 months have not been well at all. So whether it's an acquired problem or a congenital, even a big sister malformation, respiratory, may not be so very good all these days, but the parents may have not noticed that. So first thing is this is acutely presenting or chronically presenting, and if acutely presenting recurrent in the past or this is the first time presentation.
So the cough was dry in nature, not associated with the post-acute vomiting. Fever was undocumented, mild to moderate, intermittent, active in interfebrile period, not associated with rash or rigors. And there was increased work of breathing in form of retractions and tachypnea. There's no history of bottle feeding, no history of bluish discoloration, suck rest, suck cycle, or forehead sweating. There is history of previous two admissions. During the first admission at the age of 1.5 month, admitted for 15 days. The mother said it was for pneumonia, and child was intubated for 4 days. Child received two blood transfusion during that period, and child was discharged on some oral medication, likely hematinics. During second admission at the age of 3rd month, for pneumonia with malaria was diagnosed, and child was intubated for 6 days during that period. ANC and birth-wise child is normal. There is no history of any fever with rash during antenatal care. Anthro-wise also child is normal and immunized till 1.5 month. Developmentally appropriate for age and exclusively breastfed.
Okay, so just two, three small general things for history. I know you are junior. So cough is not associated with post-acute vomiting means what? What is the
So dry cough is upper respiratory problem, no? Now we are talking about breathlessness. So what? It's a laryngeal problem. No, and it's not pharyngeal also. Could it be the nose is blocked? That's why he's breathless. So why dry cough? We expected a wet cough.
So what I'm saying is that this one is, sir, what dry and wet. Second, this post vomiting. I'm just asking, understanding. What does it mean to you? Suppose somebody post vomiting and somebody doesn't. What is your inference?
With the airway is something that we are looking at. Uh,
Yeah, but how does post vomiting add or subtract from your inference?
Child usually swallows the sputum and is not able to cough out. So when they swallow and after bouts of cough, they will vomit out the mucus also. If it is containing mucus, it is equivalent to productive cough.
So that is a different issue. That if and when they vomit and if it contains mucus, it is equivalent to productive cough. That's a different issue, though even stomach contents has mucus. So that's not a 100% direct correlation that if you get sticky mucus in vomit, it means it's a wet cough. So post-tussive vomiting just means that the coughing is so severe that it leads to vomiting. So when your history itself is not of severe cough, this description or this expectation that there is post-tussive vomiting or no should not be there.
Bronchiectasis has severe cough, but no post-tussive vomiting. Correct? So why is that? It's a severe cough. So the point is that when there is an irritation in the airways, but nothing can come out, then you go on further trying to push it out, and then you vomit. And therefore you vomit only when there is either no cough and you still have an irritation. So you keep on coughing. So cough becomes severe. It could be pharyngitis also, or it could be lower airway where the mucus secretions are sticky or there is an obstruction. An asthmatic may cough and say, oh, it's dry cough, nothing comes out because there is a bronchospasm. So this post-tussive vomiting suggests that there is one of the two, either upper airway, but upper airway rarely is breathless. So it's a lower airway and lower airway with obstruction. What kind of obstruction? Bronchiolitis is almost an obstruction. Distal bronchi, small diameter in a young infant, and they cannot have enough pressure to throw out any irritation, and then they cough and also that. And what do you mean by subsequently uh, increased work of breathing in the form of retraction? What is that?
So these are descriptions that we use in the history, but it's difficult to get this from the patient, no?
But she has
Yeah.
said something further.
Retraction and
Yeah.
tachypnea.
Yeah, okay. What
So,
about the past illnesses?
now come to the past illnesses. What do you make out of this? So, history of first admission at the age of 1.5 months for 15 days for pneumonia. So, first lesson that we want to teach you is whenever you get such a history, ask the history of that time. Okay, what were the symptoms? So, confirm that does it sound like a pneumonia. So, what happened at 1.5 months? Any details you know?
The child had fever, cough, cold for 2 to 3 days at that time. Child was admitted at our hospital only in PICU for around 10 days and then 5 days in ward. In that period, child was intubated for 4 days and uh, then
Okay.
subsequently
So
extubated.
there was high fever that time
Yes.
also.
And that time they I was only there in PICU. Child also had wheeze on auscultation.
Okay.
In other admission, there is no wheeze associated.
ठीक है. So here तो we are lucky that you were only there at that 1.5 month admission. But
No, the child had pneumonia was also there.
Was there.
Yes.
But otherwise, now how would your thought process go? So this is a definite respiratory ailment at 1.5 months of age in a normal breastfed child growing well. She's told us today also the growth is good. What would be your thoughts?
Doesn't seem to be a uh, lung parenchymal disease or chronic disease. It doesn't seem to be a chronic disease for sure. But
No,
these are
that issue is a 1.5 month old baby gets a severe respiratory infection. She's saying it was a pneumonia. What would be your thought on this thing?
First thing is should not have got. If it got it, I have to think twice. Maybe it's a chance, less likely. In a breastfed baby, unless there's a very close contact, 15 days baby is reasonably isolated. No chance of getting such an infection. So everything looks unusual. So there must be something unusual underlying. So immunodeficiency possible, maybe a rare case of pneumonia in a small child. But first thing is anything slightly outside the usual thing appears, your thinking also should go on something outside. So immunodeficiency is first thing. Congenital heart. If congenital heart, left to right shunt. That means increased work of breathing, increased precordial active cycle. If they were there, there should have been additional proof. So probably no congenital heart predisposing. Immunodeficiency quite likely, though we are not very sure. It took so many days and he was intubated. It was a bad pneumonia. Was it a small pneumonia or a big pneumonia? So small pneumonia intubated, maybe there must have been bronchial or disease also. The small patch of pneumonia, localized affection, this child wouldn't have required. There must have been generalized disease. There were bilateral bronchi, etc. At that time, I don't remember. There must have been a generalized disease with a localized symptoms. Otherwise, wouldn't have been intubated for 5 days.
And then there was a second illness, second admission, received 2 blood transfusions. What do you think of that? So do you think this was a hemolytic anemia? Come on, what are your thoughts on a 1.5 month old baby receiving 2 blood transfusions following a pneumonia? Is it mycoplasma with hemolytic anemia? Come on.
Could it be physiological anemia of infancy?
Would they need a blood transfusion?
Sir, मतलब acute event with photo requirement they might require.
So in general, this was a very sick baby. So this blood transfusion, whatever details we can get later, this is related to the sickness and possibly not related to something like a hemolytic anemia that I'm talking of, right? So that is the concept that you have to develop.
And also at 6 months, she was not so pale. 6 weeks, sorry. First admission was not so pale to consider a transfusion. And in 6 weeks more, at 3 months, she was pale enough to require admission. Am I right? Second
No,
admission at 3 months. First admission at 6 and
1.5 months च्या admission मध्येच 2 blood transfusions.
Oh.
And second admission is at 3 months for again pneumonia with malaria. And intubated first time also. So now second pneumonia. So what do you think now? Same what sir said, that immunodeficiency or something wrong with the host is for sure, right? Okay. And then she said present growth. What do you think of the growth? Very good. Looks quite normal for a 5-month-old baby. Okay. So come.
I think the child is doing so well and has had 2 admissions, ventilation, okay, intubation. So looks very unusual. Okay, after all, uh, because we don't understand, we call it unusual. There's nothing beyond that, but 2 blood transfusions at the end of all that. So looks something very, very different. And if the baby continues to be good, exclusively breastfed, that means possibly growing well, then the question is, was it pneumonia at all? And I think 2 diagnoses that is commonly given on the history, typhoid and pneumonia, are neither of the two mostly when you get into detail. But this shall require intubation. Now, you can't get intubation in a pneumonia which is not pneumonia. And therefore, they are not very sure what happened. But anyway, let's see on examination what it is.
5-month-old male child case of fever cough cold with increased work of breathing is probably a case of recurrent bronchopneumonia in a partially immunized birth and developmental normal child to rule out cystic fibrosis and congenital heart disease. On examination, child
Baby
was
is not here, no?
no child is on nasal prongs.
Okay.
Um, child was afebrile with heart rate of 145 per minute, respiratory rate of 54 per minute, saturation maintained, peripheral pulses were well felt and extremities were warm. Head to toe examination was normal with AF open at level. System examination. On inspection, shape was normal, symmetrical, chest rise equal on both sides, no scars, trachea was central, tachypnea present, and SCR and ICR was present. Um, on palpation, trachea was central and chest expansion equal on both the sides. On auscultation, air entry was bilateral decreased, wheeze was present, and creps were present bilaterally. Um, on abdominal examination, soft, non-tender with there was hepatomegaly of 2.5 centimeter, soft below right costal margin with span of 7 centimeter, left lobe just palpable, and spleen of 3 centimeter, and rest systems were normal.
What do you think of these findings? Shall we try and analyze them? So you have tachypnea with subcostal and intercostal retractions. So subcostal retraction suggests what?
Lower respiratory, intercostal, subcostal, and suprasternal also suggests that it's a disease where there is pulmonary or alveolar infiltration. Okay, for example, anything which gives rise to alveolar infiltration, air trapping will have, asthmas will often have. Intercostal means alveolar lung disease, pulmonary. So this child probably has both. Pulmonary lung disease has also produced significant. At the end, everybody will have suprasternal, and but in the beginning, if this was prominent, then probably this child has pulmonary disease, pneumonia, as well as significant respiratory distress, maybe hyperventilation in other, I'm sorry, infill, what shall I say, air trapping in non-affected areas of the lung also. So both the things are there. Probably. So alveolar disease and perhaps bilateral generalized airway disease.
And what do you think of the liver spleen?
Enlarged liver and spleen. Child is in failure.
So why spleen? So remember, this is a tachypnic baby, so this could be pushed down also. So there's an element of that as well.
I think 3 centimeters looks quite significant, and more so because the liver would have been also pushed down a great deal. This child has 2 centimeters liver and a 3 centimeter spleen. The spleen is little bigger and then therefore pushed down less likely. So and required a blood transfusion. So question is it some hemolytic anemia itself, not related to fever, etc. But we don't know what exactly this fever was. At least this time on examination, the child looks reasonably well. Uh, I, the growth was normal, right? Growth was normal. So growth normal in spite of two admissions at 1.5 and 3 months. Okay. So we don't know. You said intubation, but not ventilation. Intubation is fine. Somebody might, because you have a scope, so you go in and see what's happening. It was not ventilation. Ventilation, so required a ventilation. So I can't push two together at all. The only time that one has seen a repeated ventilation and a child normal growth is an upper airway obstruction. And that moment you put in the tube only, they are all right. They don't need to be ventilated. Okay, but somebody must have put into and put on the ventilator. Everything was all right, but they don't have fever, pneumonia, etc. So yeah, so I think look something very different. So again, we are foxed. Today is the day for us to get totally out of normal thinking. So let's see what has happened. Yeah.
But was it normal? What was the weight?
6.1 kg at 5 months and length 67 centimeters.
2.5. So, 5-month-old male child, case of recurrent bronchopneumonia with splenohepatomegaly under evaluation to rule out infective versus non-infective etiologies. Yeah. So this is the X-ray during second admission when the child was admitted for pneumonia with malaria, and second X-ray is current admission. I don't have the X-ray of first admission. Um,
Comment on the X-ray, please. First X-ray. Cardiomegaly, no cardiomegaly. Probably not. It is looking like that. Cardiothoracic ratio are different. And in AP and PA view, the heart may appear a little more than what it is. The lung fills are not, there may be something on the right side here. But comment on the abdomen.
Splenomegaly,
Such a
liver.
big spleen. Such a big spleen there. See, liver and spleen. And if you can actually count the span here. See, so much of span. And the spleen is definitely seen. So don't forget to see the spleen on the chest X-ray. And the second side has something in the upper lobe, something in the middle lobe, right side, and the spleen has regressed to a certain extent. Right? The liver is remained more or less same perhaps, but look at the bones also. There's nothing much in the bones. First X-ray is centralized, second X-ray is centralized. There is no increase in the cardiomegaly. Lung fills are within normal limits. No evidence of any rickets on the upper end of humerus that you see. Otherwise, sometimes you may see little cupping.
Sir, considering that this child needs prolonged respiratory support, is it an interstitial anatomy that is affected? And if so, then can it be histiocytosis, liver, spleen, interstitium of the lung?
I think the liver and spleen there, either if it's related to respiratory, then it's pushed down. And then if you see the diaphragms, they're getting little flatter. They're not nice a curve there. So the question is whether there is an air trapping. And if it's an air trapping, you're right. You're giving one of the probabilities of an interstitial lung, but mostly that should not really come with episodes of breathlessness and so on. It should be a continuous process, either acute or chronic progressive. So possibly not. But all that I find is that there is certainly an increased vascular markings and also looks like some air trapping and therefore liver and spleen. maybe hemolytic anemia, yes, but largely it could be consistent with a bronchiolitis-like syndrome, whether there is anything like an RSV, but that's unlikely because why three? When we are told pneumonia with ventilation, bronchiolitis doesn't need ventilation. Okay. And if you have an airway problem which needs ventilation, it's extremely rare, but you can just push them into pneumothorax and so on. Asthmatics rarely need ventilation, adults possibly. But in children, if somebody gets it, then I suppose it's likely that we might cause complications.
That regress, doctor. The first
Yeah.
it has probably malaria and has responded to blood transfusion. So we can explain the spleen, but two admissions in a 5-month-old child with respiratory. First diagnosis is this particular child is not born with a normal lungs or normal immunological system affecting the lungs primarily. And therefore, I would justify your diagnosis of cystic fibrosis or whatever. There may be different kinds of disease, but this child does not have normal lung function, either because of a structural problem or because of functional problem. The functional problem may be restricted to the respiratory system or a generalized.
So during first admission at the age of 1.5 month, the CBC was HB of 7.1 with hematocrit of 22, WBC of 5,100, and platelet of 3,50,000. 3,50,000. MCV was 82, MCH was 26, MCHC of 32, and retic was zero point 0.7 with RDW of 13.5. 2D echo was also done at that time, which was normal. During second admission with the malaria, CBC was with HB of 5.3 and hematocrit of 16, WBC of 3,400, and platelets of 1,01,000. The child was on hematinics at that time, and with MCV of 86, MCH of 29, and MCHC of 29. At current admission, HB is 9.5, hematocrit is 27, WBC count is 6,000, and platelets are 3,51,000. And MCV is again normal 82, and MCH of 28, MCHC of 34, and retic count of 1.6. PS is also done, which only showed hypochromic and microcytic anemia. LFTs are normal, OLD is negative, and 2D echo is normal.
I know that even malaria can cause pneumonia, though we don't see that much. Okay, but it is recorded. After all, malaria falciparum typically can have a cerebrovascular episodes. That means any vessel could be obstructed by the clumps of the parasites. And if it happens in the pulmonary, then it might look like pneumonia needing ventilation. It could be almost equivalent to pulmonary vascular obstruction, like a pulmonary embolism in an adult, acute onset. Okay, and then getting better. I wonder, we must look at the literature. I'm not very sure, but we know falciparum malaria with cerebral problems. It is related to vessel, whether a pulmonary vessels are also involved. I'm aware that pneumonia is a manifestation of malaria, but it may not be pneumonia, but it could be a vascular, like a Wegener's granulomatosis looks like pneumonia, but it's vasculitis. So this is a malaria vascular issue, maybe, and that is recurring, and that might be uh, also responsible for your liver and spleen. That may be all right. Now, my question to you is, what test for malaria you will do now that he does not have active malaria? He has had 1.5 months, 3 months, now he's 5 months. So I'll give you a clue. Which malarial test may remain for next 2 months, even when malaria is gone? That test is worth doing.
Come on, your rapid antigen test remains positive after malaria or it gets negative immediately.
So the antigen test may remain for few weeks. Okay, 2 months might have lost now, but it might be worth doing it even now to say that yes, it was malaria kind of. Yeah.
Sometimes you'll pick it up on the marrow when you don't have it on peripheral smear. And the so-called tropical splenomegaly, which you see in adults, where you do only the IgM and everything else is not in favor of and consistent of IgM, but not applicable to at this age.
So how is this baby now?
The child is on nasal prongs right now.
Tachypnic.
Oh, yes. Yes, tachypnea is there. Intermittent tachypnea is there.
And no fever.
No fever. Yes.
So means this, forget the previous ones, but this episode then all only needed oxygen. That's
Yes.
all.
No intubation required this time.
So this episode needed just oxygen, and the child is now fine.
Yes.
Was it dyspneic on admission?
Yes. There was SCR and subcostal and intercostal retractions.
Rajesh, can I say something?
Yes, yes, Anjali.
I think this should where there is repeated aspiration to the lung. Just a thought.
Repeated aspiration, you are saying.
I could not hear you.
No, no, you are saying repeated aspiration.
Or H fistula, like an esophageal fistula, which is like an H fistula,
Okay.
a tracheoesophageal fistula, where there is no real lung parenchymal problem, but it is repeated aspiration through the fistula. So an anatomical problem.
I think repeated aspiration is the GERD, right? Not only GER. And moment you say D, there has to be a failure to thrive. So this is not micro aspiration or really a GRD. So to that extent, and there is no reason for any other reason. Exclusively breastfed baby gaining weight well. So there is no aspiration in this child.
Sir,
But
she's saying structural malformation.
Structural
like an H
malformation,
fistula.
structural malformation presents as pneumonia only. Sexual malformation is a silent problem, never presents at all, and it presents with typically pneumonia, and pneumonia gets well with our treatment, but the second pneumonia comes in the same lobe, and
Sir,
that is the time we pick up congenital malformation. The only congenital malformation in the respiratory tract that may present really because of malformation is a diaphragmatic hernia, and that might present even at birth. It has been prenatal also, and that causes agenesis of lung involved. So, barring that, all malformations are local. To me, this is a vascular problem. Malaria can give rise to that. There is evidence of a severe anemia, and she put up 1 second ortho pneumonia with malaria. I started thinking whether malaria causes pneumonia or pneumonia causes malaria. So obviously it's the malaria causes pneumonia or both together, but I still feel malaria may be a diagnosis. Okay, we'll have to look carefully about it. I look at the literature, but I know malaria with vascular complications can involve pulmonary as well.
so they are talking of tracheoesophageal fistula, like a H type
No,
of
no,
a
H type
fistula.
doesn't present so early. H type presents much later because they manage to kind of continue. H type fistula I've seen at 8 and 10 years of age. Okay, all that happens is sometimes a little choking, but he manages and there is no complication. Again, H type fistula depends on the fistula is never horizontal, fistula is some oblique. So depends on that. If the oblique fistula is airway uh, end is at the top, then you will have a stomach bloating up. But if it's the other way around, then there would be aspiration. And if it's a fistula is small, it can just go on with cough. One of the common cause of chronic cough, which is difficult to diagnose, is an H type of fistula. So not in this child, and
So,
he won't come with fever and ventilation and so on.
So
To me,
Anjali, the history means the history in aspiration should have been much more prominent cough, whereas in this child immediately there was breathlessness each time. That was one, and the second X-ray that we have of the second episode, that doesn't look like aspiration at all. I mean that X-ray nearly looked okay. So these are the points for and against. I mean, good that all of us are thinking. Any other suggestions or points from Palniraman? Any questions from any of the viewers on either of the two cases?
Will be worth doing a bronchoscopy and also a dye introduction into the stomach. And while doing bronchoscopy, one can see if the dye is coming into the faculty. Had a patient like this presented in a very early age, and we did a dye test.
Dr. Palniraman is unable to unmute, so he is saying CBC is not suggestive of bacterial process, looks like bronchiolitis like illness, either RSV or human metapneumovirus, and they could be different viruses. And again, he's saying usually H type would produce recurrent pneumonia.
The second X-ray unequivocally shows pneumonia on the right side. Second X-ray shows. Also, it was nice to have pointed out that we must think of at the back of mind any in a recurrent lung disease G or D and S type of fistula. That was, I think, what Archana wanted to say. But I thought, like what Rajesh said, airway, it is the airway primarily involved, and they will come for recurrent cough and some LRI. This child has come primarily for LRI, and the second X-ray shows pneumonia. There are two small patches of pneumonia in this particular. It's a parenchymal disease. But we'll keep that in mind that any recurrent cough, we keep congenital problems, including GERD and PE fistula of different types.
and I think none of the airway disorders need ventilation. It has a parenchymal involvement. So, to me, which airway disorder you need a ventilation? Okay, almost none. So, to that extent, two episodes. Which airway disease has fever in a prominence? Okay, again, unlikely. So, what looked like a viral infection to begin with only on this history, but the past history pushed us to something else. Let's say that this child has anemia, and anemia must be malaria only. In this child, you have a liver and spleen. Question is, can you push malaria into respiratory problems? And that's why I feel that is more rational to consider. Malaria is reasonably right. Okay. And malaria can cause respiratory problem. So I would say this is really unusual case of malaria presenting with respiratory problem. That would be the best bet.
Sir, mostly the past episode must be malaria. Now the present episode must be this thing, here, bronchiolitis like illness presented by the virus, caused by the virus. And the third thing, H-type fistula, usually the aspirations can be from above or from below or from middle. And usually from above means usually there will be usually the already abnormal child, not a normal child. And from below only after feeding the aspiration occurs. But during H-type fistula, usually aspiration occurs while feeding. Usually that's known by pulmonologists say you have to watch while the child is feeding. And the feeding, during feeding, you can see the coughing, particularly during the feeding. It can be observed only diligently when you follow the baby. This has happened when, particularly in terms of H-type fistula, and they have proven by bronchoscopy and endoscopy, both the thing together. And usually they present with recurrent pneumonia, sir.
Yeah. Okay. Thank you, Palni. Okay. Fine. Any other comments or questions from the online audience?
Sir, first case, any endoscopy done for varices, sir? First case?
No, they've not done an endoscopy, but the USG didn't show any portal hypertension. USG Doppler didn't show.
Okay, thank you, sir.
Okay, fine. So I think we'll stop here. Any questions from here?
Yes,
Anybody?
today we had
Yeah,
attendees,
Anjali.
we had 35 attendees, which has now come down, but today was more than last one, which was 25. So we
Okay,
are
great,
increasing.
great, very good. Thank you.
In spite of Shivratri.
Thank you,
Thank
everyone,
you.
and we
Thank
meet
you,
next
sir. Thank
Thursday
you,
again.
Ambedkar, sir.
Thank you,
Thank you,
thank
all
you,
Answer to
faculty.
second child
thank you.
will come
And
after.
thank you, all presenters.
If you fall sick again,
Thanks for good learning, sir. Thank you for learning, sir. Good learning from
Surya
everyone.
Excellent
and all these
learning.
are contributing, and he will never fall sick.